Welcome back to The Explainer. Today we're unpacking the intense scrutiny surrounding brain dysfunction documentation. Specifically, we're taking a deep dive into encephalopathy and exactly how to compliantly validate it. Diagnosis of encephalopathy, whether we're talking metabolic, toxic, septic, or hepatic, are facing massive commercial payer scrutiny, clinical validation denials, and recovery audit contractor clawbacks. And you know when this happens most often? It's when a serious condition is documented merely as generalized lethargy or mild confusion without any objective clinical tracking or causative workup. So today, we're going to fix that by mastering the 2026 AHIMA and ACDIS compliant query standards.
Here's our roadmap for today. We'll start with validation scrutiny, compare vague symptoms to validated diagnoses, look at objective clinical indicators, learn how to structure a 2026 compliant query, and wrap up with defending the record.
All right, let's dive right into Section 1, Validation Scrutiny and External Audits.
Listen, to really tackle this, we first have to understand the massive financial and compliance pressures facing healthcare organizations right now. Recovery audit contractors, or RACs, are actively hunting for cases where complex diagnoses like encephalopathy are coded, but the clinical indicators in the chart only point to a mild, transient symptom. As this 2026 AHMA and ACDIS guideline quote brilliantly illustrates, the environment is increasingly emphasizing clinical validity and defensibility. Organizations literally have to shift away from volume-driven documentation just to defend against these audits. It's just no longer enough to have a provider jot down a diagnosis once. The entire medical record has to be clinically grounded and highly defensible to accurately represent patient complexity.
Moving on to Section 2, let's look at vague symptoms versus validated diagnoses.
This is the exact battleground where clinical validation denials happen. It's that clinical ambiguity between a mere symptom and a true pathophysiologic disease process. Altered mental status, or AMS, is a broad, nonspecific symptom describing a change in cognitive function or level of consciousness. Encephalopathy, on the other hand, is a true pathophysiologic disease process characterized by global brain dysfunction. It requires a systemic workup. Think about the etiological classifications. You have metabolic encephalopathy driven by severe electrolyte derangements or uremia. You have septic encephalopathy driven by systemic inflammation. Hepatic encephalopathy marked by elevated serum ammonia and asterexis, or toxic encephalopathy caused by medication interactions. The point is, you absolutely cannot treat these as interchangeable terms.
Which brings us to Section 3, the power of objective clinical indicators.
So the crucial question is, how do we actually prove we're dealing with severe brain dysfunction and not just a patient who is mildly sleepy after getting some pain medication? Well, you have to rely on acceptable sources of objective clinical indicators, and these can be compliantly sourced from multiple areas within the current or relevant prior encounter. We're looking for diagnostic workups that validate encephalopathy. This includes neuroimaging, like a CT or MRI of the brain, to rule out acute structural strokes, EEG reports showing generalized slowing or triphasic waves, and laboratory panels like ammonia levels, ABGs, or comprehensive metabolic profiles.
But it doesn't stop there. To validate global brain dysfunction, you really must track neurological deficits precisely. You want to look for objective markers, like Glasgow Coma Scale scoring, serial mental status assessments noting obtundation, or physical examination findings like asterexis. Utilizing objective tools like the mini-CAW or the clock drawing test is incredibly valuable here. A score of 0 on a CDT, noted by nursing or an attending, is a concrete, objective indicator of cognitive impairment that you can use to build a rock-solid clinical validation case. Let's look at this in action. Imagine a patient with severe sepsis, worsening asterexis, and disorientation that requires a constant sitter. If that is documented merely as acute mental status change, well, that's incredibly vague. A validated workflow, however, translates that acute confusion, elevated WBC, and hypotension into a tracked, causative workup, something like evaluating for septic encephalopathy secondary to urosepsis while pending cultures. See the difference?
Let's get into Section 4, Structuring a 2026 Compliant Query.
Here's your step-by-step framework to ensure your query adheres strictly to the newly updated 2026 AHIMA and ACDIS guidelines. Whether you're dealing with a patient showing transient somnolence from a narcotic or an ICU patient with metabolic encephalopathy, these 3 specific steps guarantee your query remains compliant, highly defensible during an audit, and most importantly, ensures it doesn't lead the provider or introduce unsupported diagnoses.
Okay, remember, the absolute golden rule of the 2026 guidelines. You cannot interpret the data yourself. Zero subjective interpretation. If the record says lethargy,
You must quote it directly. You can't insert your own diagnostic assumptions. If a lab report shows a sodium level of 122, you state the exact value. You do not write hyponatremia as your clinical indicator unless a provider has already explicitly diagnosed it.
Look at how this maps out in a real case study. You combine exact quoted symptoms like lethargy and confusion with objective lab data, like a WBC of 16,500 and a positive E. coli culture. You present these facts objectively, then pose a non-leading question, such as, please clarify the condition being monitored and treated. Only then do you provide clinically supported multiple choice options like metabolic encephalopathy or UTI.
And to stay fully compliant and non-leading, your multiple choice queries must always give the provider an objective way out. You absolutely have to include options like other explanation of clinical findings, please specify, and unable to determine. That term, unable to determine, represents true clinical uncertainty, which happens. Also, keep in mind, your options or query titles must never, ever reference the potential reimbursement impact or DRG shift.
This 2026 guideline provides a vital defense against payer denial tactics. By following the compliant query structure we just discussed, you prove that the diagnosis of, say, hepatic encephalopathy was established by the provider's independent clinical judgment based entirely on the clinical indicators you neutrally provided. It effectively blocks auditors from claiming the provider was led to a higher-paying code.
Finally, let's wrap up with Section 5, Defending the Record and Severity Impact.
Let's examine the real-world impact here and how this accurately captures the severity of your patient population. A non-compliant query, maybe one with a leading title like Query for Metabolic Encephalopathy, is going to be thrown out by auditors instantly. But a compliant query, one resting on objective data like EEG results and Glasgow Coma Scale scores, utilizing a totally non-leading title, that becomes a permanent part of the health record. It stands firm and defends your DRG assignment.
Ultimately, this whole rigorous validation process, it isn't just about passing compliance checks. Accurately documenting specific types of encephalopathy, which, remember, are classified as CCs or MCCs depending on their severity and underlying etiology, actually drives your MS-DRG severity tiering. It ensures your severity of illness and risk of mortality scores are highly accurate. And it rightfully reflects the intensive nursing, sitters, and monitoring resources required to care for these highly complex patients.
So, I want to leave you with a question to provoke a quick review of your own CDI practices. Go check your templates, ensure they are capturing the objective clinical indicators of brain dysfunction, and make absolutely sure they are truly non-leading. Please like, share, subscribe to Decode Healthcare with Harshal.